please welcome Dr. Jose David Rosales Figueroa from Centro Medico Integral, Guatemala. Dr. Jose, we can't hear you. Your mic is muted.
Good morning, good afternoon for everyone. The day is starting here. Can you hear me well? Can you hear me well? Hello?
Doctor, we can hear you.
Okay, good. Well, so the topic today is about melasma. Okay. Let's see.
Okay.
Okay, just let me. Yeah. Okay, so thank you for the opportunity to present in this Congress. Melasma, a hard stone to break. I'll just share a few cases that we had with Q-switch laser in the clinic, and how it goes, and what we can do to make it useful. So to start with, we already know melasma is a chronic hyperpigmentation disorder caused by multiple factors, but mainly by sun exposure and the sexual hormones, and the prevalence of population with the disease is all types of skin that would be in Fitzpatrick pattern 3 to 5, which is light brown to brownish skin. And in Central America, we're Hispanic, and we all have this kind of skin type in between any of the affected areas. So in Guatemala, it's really high prevalence of the disease. In some areas, it's the main cause of consultation. In some other areas, it fights with acne, but most of the patients come with both. It follows the tendency of the worldwide melasma prevalence that affects mostly women, but also in men. And we see in men, it becomes, it depends on the place where these men live and what they do. So just as a diagram of how it works, and we already know the main is the main cause factor is a UV radiation. It depends on how long the patient is exposed to this UV radiation, mainly UVA and UVB, and the altitude, how close to the sun we are. The higher the altitude, it's the higher the risk of getting melasma. And with the heat, we've seen that there's some sort of radiation with heat in patients that work by night, but they have jobs in factories that produce a lot of heat, and then they get melasma. Hormones, mainly sexual hormones, estrogen, and basically estradiol, we already know, estrogen and progestins, but estradiol is the main cause of disease in melasma that goes with the hormones. And estrogens induce melanocortin receptor 1 that increases the transcription of tyrosinases, and giving as a result a higher level of pigmentation. Also in men, it's been found that lower levels of testosterone is present in patients that have melasma. Stress hormones like ACTH and melanocytic stimulating hormone activate also the melanocortin receptors, producing a higher increase in pigment formation. And neuropeptides, some neuropeptides in a study in South Korea, they found that this induce the tyrosinase activity. Genes, it's a pattern. At least one or two family members of a patient with melasma will have some degree of melasma. It's been found the gene H19 to be a factor inducing pigmentation. Also, the increase in the presence of transcription factors of tyrosinase related protein 1 and tyrosinase related protein 2, alterations in the WNT pathway, and some other genes. But basically, it follows there's some activation of genes, and we can also find pro-inflammatory genes upregulated. Inflammation, we've seen it in melasma, and all the studies that we can find there's also some sort of inflammation, higher levels of interleukins, higher levels of PPAR gammas, higher levels of a skin reaction, and it's also induced, and it's not just acute inflammation, but it's also chronic inflammation. And I would make a remark on this because chronic, the thing is, melasma goes with chronic UVA exposure, chronic hormone stimuli like pregnancy or chronic use of oral contraceptive, chronic stress, chronic inflammation, chronic heat exposure. So it's not something that will happen in an acute way. It's something that will happen with the chronic exposure to the factor. And it gives us, as a result, melasma. Clinically, in Guatemala, the most common presentation is centrofacial presentation. We also know we have facial and we have extrafacial presentations of melasma, but mainly is centrofacial. We have patients in between late 20s to the 50s, the most affected population. The indigenous population is more severely affected, and that could also play a role because most of our indigenous populations live in the mountains, which they have a higher risk because they live in the altitudes, and probably it would be another factor besides the Fitzpatrick pattern of the skin. Men occupied is the occupation of men is related to the disease in men. Sun exposure, time exposed. If they work in the fields agriculture, it's going to be more frequent to have men with this condition. So why is it so important to do something with melasma? And why it's not just a cosmetic issue, is a disease issue, is a problem, and we should see it as a disease and not just like a cosmetic. And that's because melasma lowers the quality of life of the patient, and it causes social problems with the patient. It could be how the society sees the patient, or how the patient sees himself inside the society when he's suffering from melasma. And that leads to economic load, because the patients will seek to go to one doctor, to one cosmetic salon, to another naturopathy. He will try to seek a way to clear the melasma, and most of the time unsuccessful because of the nature of the disease. And that will have a big impact on his life. And the emotional side, some people don't want to go out. They feel they have lower self-esteem, and some even have had some tendency to try to kill themselves. And all these three factors lead to the lower quality of life in patients with melasma. And it's already classified the Melasma Q, which is the scale to evaluate the quality of life in patients with melasma. Q-switch laser, basically it's all lasers target pigment. So it's a melanin removal tool. But the problem is that Q-switch lasers and all lasers basically have the problem that after you use them, there's a high recurrence rate in melasma. Depending on the laser you have, how fast it is, you can have higher or lower risk of post-hyper or other hypopigmentation. Being the tendency to be a hyperpigmentation after treatment with lasers. Pico laser is better, but we don't have a pico laser in Guatemala, so we keep with the Q switch. And the recommended treatment is a laser toning technique, which is basically using low fluence laser on the patients with melasma to try to avoid having a hyperpigmentation post-treatment, and multiple sessions. That's what's recommended, and we try to replicate that recommendations in this series of cases. Green pea extract. Green peas have been found to be antioxidative, anti-inflammatory, and a tyrosinase inhibitor. It also restores the base membrane of the dermis and the epidermis, upregulating the fibroblast growth factor number 7, also, which helps by repairing the membrane, the dermis and the epidermis in the patients with melasma. It helps avoid the hyperpigmentation. The flavonoids are really important because they induce DNA repair and some apoptotic induction in cellular proliferation that are not working well in the skin. The phenolic compounds, antioxidative, and we have the ferulic acid that comes in the green peas, the saponins, steroid phytohormones, tannins, etc. Help reduce the risk of having melasma. So why we decided to use green pea extract is because it has lower risk of inflammation and irritating the patient when using it. So our study, we have 10 female patients with epidermal centrofacial melasma, and it's really important to notice it's epidermal, not dermal melasma. It's just epidermal, and it was evaluated with a dermoscopy. The mean age of the women were 39 years old. The quality of life scale was measured before and after the treatment, and also the MASI index was evaluated before and after treatment. We used a patented laboratory green pea extract to be sure that the concentration of what was being given to the patient was homogeneous. This was started 2 weeks before the treatment in order to have some sort of inhibition before doing the Q switch, and trying to prevent post-inflammatory hyperpigmentation. The equipment, we have a Best View Q switch laser, is a Chinese company from Chengdu. Is a 755 nanometers alexandrite laser with a fractionated tip, and we use it with low energy. The idea of using fractionated tip instead of a whole tip is that when you use lasers and you fractionate the energy, the damage caused by the heat from this laser will be less. And it's also, this goes with how to try to avoid complications when using a Q switch laser, invariably of which Q switch laser you use, high-end Q switch laser or lower end Q switch laser. You can, it's fractionated is the way to go, in my opinion, that to lower the risk of having complications. So the results in blue, we have the before and the after, and we can see there's really some difference in how the patients perceive their life before and after the treatment. And also in the clinical aspect, we don't see much difference, but there's some. And basically, we made a chi-square test in the quality of life scale, and we found that there was a difference, a statistical difference between before and after the treatment. But when we run the chi-square test in the clinical aspect of the disease, we found there was no significant results difference between before and after. Most of the clinical index was just a change, a slight change in the tone of the macule of melasma, but not in the size. And but that doesn't mean that the patient don't perceive it as better. And we also run melasma quality of life and clinical Massey relation, just to see with a Pearson correlation test if the values would correlate with the higher points of quality of life or with the clinical severity of the disease. And we found there was no relation, no direct relation between how the patient feels about melasma and how clinically the melasma is. It could be, there's some other studies that show that higher Massey, you have lower quality of life. But we also found some patients that actually don't have, clinically, they don't have a severe melasma, but they perceive it as something really hard for them to take. And they even take it worse than patients that have a more clinically severe melasma. So our conclusion was there was no correlation between the quality of life scale with the clinical scale. So what we could achieve with this study, basically we had an improvement in the melasma tone, improving the pigment to the point the patients were satisfied with the fact that they could put some makeup on it and feel better about it. If all the patients had a relapse after the treatment, all relapse, but the relapse was with a lower pigmentation, and the mean time from treatment to the relapse, it was about 27 days. Some patients relapsed 5 days after the treatment. Other patients relapsed 60 days after treatment. It all depends also in the occupation of the patients that were exposed to heat or to sun more frequently. They were the ones that had a shorter time before relapse. It improves quality of life of the patients, just the fact that they can make up it and not have to deal with the spot being obvious, even with the makeup. It helps a lot the patients, and there's no direct relation between the quality of life and the clinical index. So there's some before and afters. As you can see, this is what the green pea extract is supposed to do. We're trying with this to prolong this phase. So with the Q-switch laser, we remove the pigment, and the green pea extract or some other combination therapy that will inhibit the pigmentation is to prolong the phase that we will not have pigmentation. So this is another patient. It's another one. You can see how it improves slightly, but some patients better, some patients higher. You can see before and you can see after. Even the size is not changing so much in the size of the spot, but the amount of pigment we can see is less. And I would like to finish with the words of a big rabbi, Kol Oilom Kiloi Geshrai Zer Moid Vohiur Loi Lafaide Kol. And that means in Hebrew, all the world is just like a narrow bridge, and the only thing that stops us from going is fear. So thank you very much, and I hope this presentation would help you to know there's even sometimes they tell you you cannot do it with this treatment, it will not work. There's always a way to make things happen to improve and to help our patients and to help ourselves to be better every day. This is my references for this presentation, and thank you very much.
Thank you, doctor. Would anyone